Okay, good evening, everybody, and welcome to this another new program from the Indian School of Urology and the Aegis of the Urological Society of India. This is the first ever virtual OSCE, that is the Objective and Structured Clinical Examination, which is going to come in because of the COVID pandemic. The pattern of the examinations could change. If this continues, last year the National Board did the OSCE as part of the examination. So we have thought that we need to introduce that because in some of the centers it's been existing for quite some time, but it's not common for all of them. As the national board did it last year, we thought we should introduce this and train our residents also in this sort of examination. And I must thank the andrology subsection which has started this, and Dr. Hota, Dr. Raman Tanwar and their team have put in a lot of efforts to get this. It's a starting thing. So we will just have 10 questions to be addressed today. And I hope the residents will benefit from this because sometimes this would, in the pandemic time, this could be the way to go. And I also bring wishes from our president, Dr. Mallikarjun, who is held up with some other program. So he has conveyed our wishes to that. And now I would hand over to Professor Rajiv Sood, Chairman ISU, for his opening remarks. Over to you, Dr. Rajiv. Is Dr. Rajiv Sood there? Dr. Rajiv?
He is there,
Yes,
sir.
I'm here.
Thank you, Dr. Rajiv, for your remarks.
I'm sorry I've joined late. This is today unique program which we are starting, and that must have been introduced to you all, that this is starting with the subspecialty of andrology and men's health. We have chosen this subspecialty because the June month is the month of men's health, and 20th June is the International Men's Health Day, and also there falls one day of elderly, that is on 16th June. We will be having more programs on andrology and men's health, but one thing is there, that in the education, our residents, they are not able to get exposed to the hands-on training, and also they have the difficulties in the classroom interactions, and we have fulfilled that with the interactive sessions, virtual classroom, e-learning. That was our dream also, but pandemic time has translated that into reality, and very fast, and adaptability also, everybody has adopted that. Now coming back to OSCE, in the National Board of Examination, last time there was an experiment with the OSCE type of questioning, where on the large screen, the question was screened, and for 5 minutes it was displayed and answers were there. And many of the students, they were giving answers, and they even secured 100% marks. So this gives the case scenarios, and after that the opportunity to give quick response and quick answers. With this experimentation, there may be more questions in the actual exam, maybe 40, 50, but we are able to include 10 questions because we want the entire fundamental to be clear to the students, so that in the other subspecialty meetings also we can do it. Our dream is, time permitting, that we will have this kind of programs for each subspecialty, and followed by the actual program, actual exam like situation, where it will be the replica of National Board of Examination type of questioning. It will give the wide understanding of the subject, subspecialty, and it is on the line of our thinking in the vision document, in the vision statement, that we want USI to be on subspecialty based functioning, and also various programs has been designed. Today we have Dr. Raman Tawar. as the moderator, and he has done a lot of a lot of preparation along with Dr. Hota, Dr. Also Dr. Shivam. From South, we have doctors, and the whole program has been crafted. Dr. Keshav and Dr. Arun Chawla has done a lot of hard work for making this reality, and this is possible, and this is the way for the future education and future fulfillment of our vision for Indian School of Urology. So this is the template program today. This is the inaugural program today. We are going to understand many things through your feedbacks also. So let us start this program, and for that I hand it back to our secretary, Dr. Keshav Murthy.
Thank you, Professor Sood, for your opening remarks. I would now invite Dr. Arun Chawla to introduce the program on the moderators. Over to you, Dr. Arun Chawla.
Thank you, sir. Now, as communicated by Honorary Secretary USI, Dr. Keshav, and Chairman Indian School of Urology, Dr. Rajiv Sood, this first ever exercise of objective structured clinical examination for the residents is being conducted by Andrology and Men Health subsection of USI. Dr. Raman Dhanwar is the moderator of this program, and he will be supported by 4 panelists, which includes Dr. Lateshwar Hota from Odisha, Dr. Shivam Padashi from Jaipur. We have Pramod Krishnappa, and we have Vinod KV. Now, instructions for this program and how this will be conducted, I think Dr. Raman will be deliberating, and he'll be giving the instructions to you for all the residents. So this program is into 2 sets. The first will be instructions by Raman Dhanwar, followed by the questions which will be put on the screen. A break of 10 minutes where you will be handing over, mailing your responses to us with the mail which has already been sent to you and is already communicated to you. Then will be the discussion of the keys and on the subject relevant to the questions, followed by the closing remarks. Without wasting much time, I'll invite Dr. Raman Dhanwar, moderator of this program, to please go ahead with this program, and wishing the best to Dr. Raman as well as the residents for this first ever exercise on the OSCE in the subsection of Andrology and Men Health. Over to you.
Thank you, Arun sir, for this opportunity. Before we begin, of course, everything good starts because of vision of giants. So I would like to thank the giants, the USI organizing team behind which Dr. Mallikarjun, Dr. Keshav. Thank you for this opportunity. Special thanks to Dr. Rajiv Sood and Dr. Arun Chawla for this vision of getting OSCE virtually. And I just hope that we'll be able to live up to the expectations. But before we start, I would just want to give a disclaimer that this is the first time we are doing such an exercise. And there were experts saying that even in andrology, probably it would be the first OSCE, maybe globally also, who knows. So I would require some leniency from everyone, because this is the first time and we will be growing this further on feedbacks. So I think without much waiting, let me introduce you to this concept. So we are just starting with this basic presentation. So I hope everyone can see the screen. So what you can see in the screen is there's a timer which is going on. So this timer is going to tell us that, the time is running up, and this timer is of 5 minutes. So which means that we'll be showing the question as slides, and the timer will keep running, as we next slides. So there are going to be about 10 case scenarios, which are based on the theme of andrology and men's health. You will get 5 minutes per question. No question will be asked by examiner during the test. So all of you have to be on mute. We have to give this exam seriously. So what you have is that once this question comes, the scenario comes, and then the questions come, you will have to note the answers. So you can either note them digitally, say on a notepad or WordPad, or directly on a mail, and or you can also note it on a piece of paper, and then you can click shots in the end. Will give you 10 minutes after the all the scenarios are over, so that you can mail them to this address, usisecretary@gmail.com. So I think 10 minutes would be a good enough time. So once the responses are received by us, then our experts will evaluate your paper, and they would of course give you some marks at a later date. Maybe it may take a week or so, but immediately after these 10 minutes of break, we will be starting the discussion. So we will be discussing the answers to these questions, and there will be experts who will be answering these questions. So they will not just be telling you answers, but all their tips, practical tips, tricks also would be discussed. And I'm sure it will be a wonderful and healthy discussion. Now, during this discussion, if you have any questions, then you can just put them on the chat box. And in the end of the program, we will request you all my dear residents, to send your feedback on how this can be improved and how you could make use of this activity, because it has taken really a lot of time of a lot of busy people. And I'm sure that with all the good intention, it will definitely help us learn a thing or two about andrology. So now let's begin with the first question. So all the residents to keep their pen, paper ready, their notepads open, whatever way they want to choose to answer, because the timer is going to start running as soon as I start the first case scenario. So this is our first case, dear residents. So there's a 34-year-old has been married for the last 3 years, has been trying to conceive. The wife consulted the gynecologist, and the gynecologist, she ordered a semen analysis for the husband. And after looking at the result, she said that you guys should go and meet an andrologist. Now, in this such a scenario, which is a very, very common scenario, the first question is, which is the first test you would like to order in this? My second question to you all is, what are the various parameters that you would like to see in this test? So all the possible parameters that come in this test you have to mention. What are the various degrees of agglutinations?
Raman, the question should come on the screen.
What are the first-line hormones that you like to
No, slide is not moving. Raman's slide is not moving.
Question should come on the screen. Na? Yeah.
Case is coming, questions are not coming.
Yeah. Please see that the question comes.
So are the
Yeah. Navneet, can you mute all others except the panelists and the host? There's a background noise coming from.
The speaker.
Raman, go ahead, please.
I think there is some technical issue, Raman, with your internet. Navneet, you have a backup of this?
We have just received a copy, sir. We are downloading it. In a moment, we'll be able to play it now.
Sir, I will do this slide. I am just stopping to just allow it.
Shivam, you have a copy of that?
If somebody if he puts up the screen, I can just maybe.
Yeah. Now it has come. Now it has come. Raman, are you still there?
Yes, sir. I'm just stopping my video bandwidth.
Yeah. Okay. I think we can wait half a minute or a minute. Doesn't matter. Let him get ready.
So are you all able to see my screen, the slide?
Yeah. We are very much. Please go ahead.
So the first case you're all able to see now with all the questions.
Perfect. Please go ahead.
So we are just allowing the timer to finish.
Yeah.
Right.
I think there is an issue with Raman's internet. It should play
Raman,
from
you can.
Navneet, you should play from your end. I think Shivam or somebody can read
We
those
can
questions.
no, if you can play it, we can always elaborate on it. We can discuss about it.
Yeah.
Till Raman
Navneet?
comes up. Navneet, can you change the slide, please?
Sir,
After-
it is being
after-
played from
yeah.
his computer only.
Yeah. After
Let the
it
5
is,
minutes be over.
yeah. After the 1 minute, yeah. Let it be over.
Raman, you are there.
Sir,
Right?
are you not able to see or hear me?
Yeah, now
Yes,
we can
yes.
hear you. Raman, we can hear you.
Yes, sir, I
Raman,
am
we can
just
give
giving the
extra
video-
1 minute. You can just start. Yeah. For the first
sir, I
case
will
scenario,
give
we
an
can give
extra
1 minute
for it.
extra. It doesn't
Okay,
matter. Yeah. Go
Raman,
ahead. Go ahead.
you can enumerate the question now, Raman. Please go ahead. Enumerate the
Go
question
ahead.
again.
Sir, are you not able to see my first case and slide, sir?
Yeah, we are able to see.
We
Please
are able
enumerate
to
the
see.
question. Yeah, please enumerate the questions again.
So the questions are also there, no, on the slide?
Right.
Yes.
You can just speak them out.
Okay, so the first question is, what is the first test you would like to order in this scenario, in this 34-year-old gentleman? The second question is, what are the various parameters that you would like to see in the test? The third question is, what are the various degrees of agglutinations? And the fourth question is, what are the first line hormones that you would like to evaluate in male with infertility?
Hello. Kiran, there's some problem with his band.
So, sir, you can see the timer running.
Yeah, it is running. It is running.
I have given an extra 1 minute also as a compensation.
Yeah.
So I think, sir, we can move to the next scenario if adequate
Right.
time has been given.
Yeah, please go ahead.
So, sir, the next scenario is a 24-year-old gentleman who presented to you with complaints of sudden loss of erections when attempting intercourse since last 1 week. Now, my questions to the residents are, what is the likely cause of his problem? What question would you like to ask to differentiate it from other causes of erectile dysfunction? Which test can be done in the office to evaluate this patient, and how is it done? What are the ways to manage this patient? What are the options for patients of erectile dysfunction when medications do not work? So, sir, I hope the timer is running like it should,
Yeah,
and
yeah.
you can all see the questions.
Yeah, it is going on. Don't worry.
So, sir, time is running up for this question. We will have to move to the next question shortly. So the third case that we have is a 22-year-old gentleman who presented with complaints of painful persistent erection for last 8 hours. Now I'm going to present the questions to all of you. So what is this condition called? and how is it defined? What are the different types? Apart from pain, duration of erection, what relevant history would you like to ask from him?
Is a problem. Raman's bandwidth is a problem. Raman, your internet bandwidth is a problem.
Yeah, fourth question has not come.
The number of questions still left, yes. If Navneet is ready, I can
Navneet.
just read out the question.
Navneet, you can put the slides up even without the timer. We will time it in our
Okay,
mobiles
sir.
itself. You put up
Okay,
the
sir.
slides without the timer. Does not matter the
Yes,
timer if it is
yes.
not there.
Yes, sir. Yes.
I think
Question
we can
3.
put- Yeah, question 3.
Question 3.
Once Raman is back, he will take over.
Shivam, you can take over from this third question.
Yeah. Right. Make it
Very
full
good.
screen, please. Full screen, please. Right. So now we are on the third case scenario. Navneet, just click on the screen, yes. So this is a 22 years old gentleman who presented with complaints of painful persistent erection for 8 hours, right? So this is not the name of the patient, but the expert who will be discussing it later. So let's ask the questions. Go ahead, Navneet.
Navneet, it is animated, so click it multiple times.
Yeah. So the first question is, what is this condition called and how is it defined? What is this condition called of painful persistent erection and how is it defined? Next question, please. So what are the different types of priapism? Next case. Apart from pain, duration of erection, what relevant history would you like to ask this patient? Apart from pain and the duration, what relevant history would you like to ask this patient? Next question. Enumerate the steps of management in an emergency regarding this case of a painful persistent erection for 8 hours. How would you manage this case in an emergency? And the last question is, what are the various surgical options available if the patient doesn't respond to the management in emergency? What are the other surgical options available for the management of such a case?
Shivam, we are noting the time.
Yes.
We are keeping the time limits. I'll let you know once the next questions has to start.
Sure.
Prithvi has, Shivam, with your permission, just there's one raised hand is there. Prithvi, you have something to say? You raise a hand.
Sir, we will not be taking the questions right now. If there are any concerns, they're in the chat box or in the end.
Okay.
I think this is a very, very simple and doesn't need much of explanation, I think.
Last. Time over, Shivam.
Okay.
Shivam, Raman says his issue is resolved now. Let
Okay.
us see whether he can do it.
Yes,
Raman, see
Raman.
whether you can do it.
Yeah.
Yes, sir. So
Go to the fourth question.
yes, sir. So we are moving to the next slide now. So, sir, this is the fourth case. A 40-year-old gentleman complains of pain while having erection for the past 6 months, and the penis progressively deviates towards the left when erect. Now, he is worried whether he has a tumor as he is able to palpate a hard mass on his penis. So, my first question is, what is the likely diagnosis? What are the associated conditions in this pathology? What are the important points in history? Two important investigations to consider in this case, and what is the non-surgical management? So I hope all the questions are clear. The timer is running efficiently.
Now it is all
Fine.
right.
Raman is fine.
Raman, make sure that we don't have the sixth question, right?
So I'm just looking at that as well.
You don't have the sixth question there, right?
So I'm just checking it once. And if there is, then I will of course declare it well before time, sir. So there is one more question. When is surgery indicated? And then what are the types of surgery? So half the time is already gone. There are 7 questions, quick answers.
Hope everybody is not copying from somewhere and they are honest in answering their replies.
This evaluation is actually for the own good of the student only, sir.
Yeah.
So let's hope that the honesty prevails.
Yes, yes, yes.
So, sir, time to move to the next case then. Now, this is a case with fewer questions. So we can see this thing here, and the question revolves around this instrument. You can say, what is the instrument and what is it used for? That's the first question. What are the alternatives for this instrument? And what is Meerkam's maxim? These are the three questions uh, related to this figure that you can see. So the time here is more. So if you have any pending answers of previous questions, then you can try to finish them as well. So half the time is gone. And this is a picture of my own device that I have in my own clinic. So hurry up, guys, and finish whatever else was remaining previously because there are fewer questions. This is a question with fewer marks, only 5 marks. So, sir, we are going to move to the next question now. And because this question is again a short question, case number 6. So what we're going to do is, because again it's a short question, so I'll probably set the timer for just 3 minutes. Now a married couple is visiting the clinic. They are trying to have a kid, but they have been unsuccessful. Now, what are the essential points in the history to diagnose infertility as per the WHO definition? What is secondary infertility? What are the important instructions to be given to patient before sample collection for semen analysis?
Raman, the slide, there's some black thing coming. Is it only for me or something else for somebody also?
No, it is there. It is there. Black is there.
It must be the timer, sir.
Yeah. So it's good.
It's not seen now. Raman, your screen sharing is a problem. I think his bandwidth is a problem. Navneet? Navneet,
Yes, sir.
you go take over that and ask Shivam to continue with
It is
that.
six.
His bandwidth is a problem.
Sixth
I
question.
can-
Sixth
Yes, sir.
question.
Sixth question, yes, please go ahead. Navneet, please go ahead. 6. So full screen, please.
Arun, you can give them only 3 minutes for this.
Yes, yes, yes. I am noting down the time.
So this is the 6th case scenario. A married couple is visiting the clinic. They were trying to have a kid, but were not successful. So what are the essential points in the history to diagnose infertility as per WHO definition? Second question, please. What is secondary infertility? How do you define secondary infertility? Third, what are the important instructions to be given to the patient before sample collection for semen analysis? The important instructions to be given to the patient before sample collection for semen analysis. Next question. I think we have 3 questions, right?
Yes.
No, yes. Only 3, right? Okay.
So the next question will also be short only, the 7th one. So for that also we can give 3 minutes only.
Yeah. So we have 15 seconds left for this. Raman, next, please.
So, sir, this is the 7th case. A patient presented to the emergency department with penile swelling. The swelling was sudden onset following a pop sound during intercourse. So here are the questions for you. What is your diagnosis? That's the first question. The next question is, eggplant deformity, and rolling sign, they have been described for this particular condition. What are these signs? And the last question is, what does it indicate if you have noticed blood at urethral meatus at the time of presentation? What additional investigation will you do in that setting? So these are the three questions around this case scenario, and there are 3 minutes for it.
So half a minute to go.
So can we move to the
Over to you.
next? So this is the eighth case. Our eighth case is a 60-year-old gentleman. He's a diabetic with refractory erectile dysfunction, and he has come to you asking for a penile implant. Now, here are the questions around this case. The first question is, how are the penile implants broadly classified? The next question is, name any 4 perioperative infection prevention strategies that you can use so that the infection can be minimized in this case. The third question is, what are the different surgical approaches to a patient to place a penile implant? And the fourth and last question is, what are the 6 common complications of penile prosthesis surgery that you would like to counsel this patient about? So the timer is running already.
How many minutes, Raman, for this?
4 minutes, 1 second remaining.
Okay.
I will keep telling it every minute as each minute passes by. So 3 minutes are remaining, sir. So now there's about a minute remaining, sir. About 20 seconds left. So, sir, it's about time to move to the next case, the ninth case. Can we move to the next slide?
question.
So the ninth case is a 37-year-old gentleman. He presents to us 3 years after his vasectomy with azoospermia. He has divorced recently and has married a 34-year-old lady. Now, this is a new couple and they want to conceive. So now my questions are, the first question is, the most important things you would like to know on history and examination. The next question is, what are the points in favor of vasectomy reversal for this couple over ART? The third question is, what are the points in favor of ART in this case when compared to a vasectomy reversal? And the last question is, what surgeries or procedures will you take in the consent form, and what are the success rates of these surgeries in getting sperms back? So the time is now 4 minutes and 30 seconds remaining to answer these questions. So about 3 minutes remaining now to move to the last question. So 2 minutes remaining now. One minute remaining now to answer this case. Ten seconds remaining now. And then now let's move to the next case, which is the last case of this small OSCE. So our 10th case is a 35-year-old married obese gentleman who was diagnosed with Klinefelter syndrome during infertility evaluation. That was about 2 years back. And he was found to have very low testosterone levels. Now the couple subsequently had healthy twins using microtessay and IVF-ICSI, and they've completed a family. Now he presents to you for testosterone replacement therapy. So my first question around this is, what are the different formulations available to deliver testosterone to this patient? My next question is, what is the least recommended formulation and why so? The third question is that if he prefers an injectable, what medication would you start and how would you counsel the patient? My fourth question is, what is one advantage and one disadvantage of topical gel? And my last question is, investigation and their frequency for patient on testosterone replacement therapy. This is the last question. And we have 4.5 minutes remaining to answer this question. And also whatever else is left in the entire exercise for you to fill up and answer. There are 3 minutes remaining to answer the questions. One and a half minutes remaining now. Now we have 30 seconds remaining before the OSCE ends. So now it's time to end this OSCE. Let's move to the next slide. Now you have to compile all these responses and you have to mail them at this email address.
Raman, I have got responses, individual questions. I think, please, all of you residents, compile all your questions and send your mail in one of the mails of yours. If you start sending for every question a separate mail, it would be difficult to collate.
So there's a 10-minute time. It has started now. Please compile your answers and please send them at this email address. If you have noted on a paper, take a snapshot of that paper and please email it to this email address. There are 10 minutes that we are giving for this entire exercise, I think, which is a good time to be able to do all this. So after you've mailed all the responses, then what we will be doing is that we'll come to the learning part of this, and we will be giving you all the answers, precise answers, the key to these questions. And we will have our experts deliberate also further on this. And lastly, we will take out some time to resolve doubts, individual doubts, and maybe take some feedback or comments. You have 8.5 minutes to send your responses. Any responses which will come after this will not be included for evaluation. So 7.5 minutes are remaining for you to send your responses to usisecretary@gmail.com. So, sir, I can see about 150 participants here who've been answering the questions and listening to the questions. It is going to be a mammoth task for the evaluation also. So now 6 minutes remaining to send your responses to this email address.
നമുക്ക് കൈ നന്നായി സോപ്പിട്ട് കഴിയില്ലേ?
About 4 minutes are remaining to send your responses to this email address. So hurry up, guys. So 3 minutes are now remaining to send your response. So now 2 minutes are remaining for sending the responses to this email address. So friends, we have 1 minute remaining now. And I think in this minute, we can utilize this time to introduce our experts who will be providing the key to these questions and who will be deliberating. So I will be inviting the convener of the Andrology subspecialty cell of USI, Dr. Datteshwar Hota, who is the Dean of SCB Medical College, Qatar. And with him, I am inviting Dr. Shivam Pridarshi. He is the professor and head of department at SMS Medical College, Jaipur. And along with him, I'm inviting Dr. Vinod KV. He is a urologist practicing a lot of andrology with a very special interest in andrology at Cure, Thiruvananthapuram. And lastly, I am inviting Dr. Pramod Krishnappa, who is working as an andrologist at NU Hospital, Bangalore. So all the four experts, along with me, we are constituting the andrology subspecialty. And with the immense efforts of Dr. Sood and with immense effort of Dr. Arun Chavla and with all the support from Dr. Keshav and our president, Dr. Mallikarjun, we can now, we have had this first OSCE examination. And I think we should now be starting with the discussion. So I would be inviting for the first two cases that we had to deliberate on them. I will be inviting Dr. Hota to talk about, give the key and also his expert comments and guide our residents. Dr. Hota, sir, please.
Good evening, my colleagues, the office bearers of the USI and students. In fact, it is a privilege given to the andrology subsection of the USI. And Dr. Raman has done a very wonderful job in the presentation. Now, can I request Navneet to bring out the first question so that I can tell about the keys, if it is possible?
Yes, sir, sure.
Yeah. Now, if you look at the first question, 34-year young male, 3 years married, the wife took him to the gynecologist for their not having a child, and gynecologist advised a semen analysis. After looking at that, sent the patient to the andrologist. If you look, this is a very broad area, there is no specificity in this. So the first thing that you would like to do is a clinical examination. Definitely, after the clinical examination, the first test that you would like to order to have a repeat semen analysis. In the infertility management or subfertility management, one semen analysis is not proper. with all the advice how to collect, which my subsequent experts also will be telling. You look to the semen, you go for a second semen analysis after your good clinical examination. Now, what are the various parameters that you would like to see in this test? You know, if you look to the semen analysis, there is a primary analysis, there is a secondary analysis, there is a tertiary. But what actually always we do is a primary analysis, where you look to the volume, to the pH, the total number per ejaculate, the concentration, motility, vitality, morphology, seminal fructose, leukocytes, and there are a few optionals. These are not regular. You can go for MART test, seminal zinc, and neutral glucosidase. So this is the primary test, and I think we'll confine our discussion to the primary test. Now, if you look to the semen parameters, now whether to say it is normospermia and no other abnormality is seen, then you have to think about the bulk semen analysis percentile. You know, not a single or a two report of semen can predict about the fertility potential. This is a probability. Now, in that situation, we have this confidence interval. This is already analyzed, you know, by WHO over many countries, and they found that if 1.2 ml semen volume, 9 million sperm concentration, 23 million per ejaculate, and 30% of total morphology, 28% of 34% of total motility, and 28% of progressive motility, 3% of morphology. In fact, earlier it was quite high, but it has come down to 3%, and 53% of vitality. These are the things we look for. So with this, we have the confidence interval of having a probability of pregnancy over the years. So if you look to all these things, this should be the basic parameters that we should look for after having done a repeat test. If there is any abnormality, you tailor your treatment accordingly. Now, the third question that is asked is sperm agglutinations. You know, what is sperm agglutination? You know, sperm adhering without cells or debris. So that is very unusual, you know, not having agglutination. We know that if there are anti-sperm antibodies, we can see the antibodies, but here the agglutination is mostly because of the infections, because of agglutinating antibodies. Now, what are the grades of agglutination? If you find isolated, less than 10 sperm agglutinating, and many pre-sperm. And second, the grade 2 is moderate, 10 to 50 sperm agglutinating, and there are a few pre-sperm also. You have a large, if more than 50 sperm, some sperm still free, and the gross is all sperm agglutinated, and agglutinates are interconnected. So this is how the gradation is done. Now, as I said, we have to look to the pathology for this agglutination mechanism, and mostly the presence of WC, more number of WC, and the infections are the major reason. Now, then we look for what are the first line hormones that you would like to evaluate in male with infertility. As I mentioned, your clinical assessment is of paramount importance. If you find there is no secondary, secondary sexual characters are not abnormal, and testicular volume is quite good, around 15 to 20 ml, and you do not find any other abnormality to ascribe to an endocrine problem, I think most of the time we do not advise the test normally. But if it is azoospermia, definitely, if there is azoospermia, definitely we go for the evaluation of the hormone. And what hormones we look for? Mostly the FSH, which is very, very indicative as regard the spermatogenesis is concerned, FS, LHS, and of course, where we are suspecting is there is a hypogonadism, hypogonadism, or there is possibility of hypogonadism, definitely we should look for the total testosterone also. So these are the variety things. If you look to the clinical scenario, this is a broad-based scenario, and we cannot pinpoint. So looking at the parameters only, you can tailor your investigations. Coming to the second questions. Now, 25-year-old male, can you change the please second questions? Navneet?
Navneet?
Yeah. This is a 24-year-old gentleman presented to you with complaints of sudden loss of erection when attempting sexual intercourse since last 1 week. If you look to the age, he is 24, and if you look the onset, which is very short, so obviously, possibly we are dealing with a psychogenic ED. But anyway, we keep it as a provisional diagnosis, but definitely we would like to take further history like what questions would you like to ask to differentiate it from other causes of erectile dysfunction? Now, as you know, the age and the history will definitely give some lead towards what type of erectile dysfunction we are encountering in this young man. Now, as you know, the sudden onset are usually psychogenic, and young man, many a time they have anxiety. It could be situational, one failure perpetuating further failure. That's the reason he has been complaining for 1 week. So we should bear that in mind, and we should take the history very properly. Also, we should see whether he has got erection other than during his intercourse. Now, does he have a spontaneous erection in the morning? Does he with visual stimulation, does he get erection? And is it partner specific also? We have to also look to that, because in the partner specific, you have got situational problem which may lead to erectile dysfunction. And we should look whether the course is progressive or not. And we should, in the history and examination, does he have any systemic illness? That also you should look for. And finally, also we should look for any history of trauma to the perineum. And these things will give us a lead. And if we have any doubt, then further the question is which test can be done in the office to evaluate this patient, how it is done. Now, usually it is recommended that in a psychogenic or maybe organic, the first test, even if we have the history and we are pinpointing at psychogenic, and if we do not find any lead information as regard the erection in other times, then obviously a office sildenafil test that we should always practice. And all of you know that office sildenafil test is a very simple test. You can perform it in the office. You can start with 100 milligram if the person is very anxious. Otherwise, in a little elderly person, you can make it 50 milligram also. But 100 milligram is the standard sildenafil. 100 milligram is the standard dose that we give. And the precaution of giving him in little pre-fasting, in the fasting state, not with fatty food. Then we give him privacy, we give him space. We ask him to have visual stimuli if required. And we periodically monitoring after 10 minutes, 15 minutes, we see him whether he's having erection or not. And once one sildenafil test may not be adequate, we can repeat the sildenafil for the second time. If you are failing to achieve the man is failing to achieve an erection in the first sildenafil test, a repeat sildenafil test can also be done. Now, this is the usual office test that we do. But if you are not finding an outcome out of the sildenafil test, we can always go for the next is the ICVAT test. A person who is too anxious, who has a lot of stress and strain, may not respond to a sildenafil test before you say the sildenafil test is negative. Now, in that case, we go for the ICVAT test. And the ICVAT test, as you know, that we have so many drugs. You can use one drug, you can have bimix, you can have trimix, and you can have quadrimix. So before we say that it is organic, we have to do this all office test one after the other. Before a young man of 24 years, we can say that possibly he is suffering from an organic cause. Unless ruled out, we will definitely evaluate for a psychogenic cause. Now, what are the ways to manage this patient? Now, this fourth question, what are the ways to manage this patient? As you know, if their office sildenafil test is positive, not to go ahead with any further testing. And the best thing is to go for a counseling. The man should be taken into confidence. We would try to know what is the triggering factor for the erectile dysfunction. What are the psychological stress and strain this gentleman is undergoing. And that is how we have to counsel him. And many a time the patients may get relief with counseling. If sometime we may give also some antidepressant for a short period of time. And if the office sildenafil test is positive for him, then in that case, definitely we will advise him to take sildenafils for his few initial encounters to revert back a normal sexual life. So this is what the procedure you should follow. What are the options for patients of erectile dysfunction when medication do not, succeed? Now, this man, young man, we always feel that possibly he is having a psychogenic ED, but to rule out for further evaluation, if we have failed in all these evaluation, and we are not able to achieve, then of course we should go for a Doppler testing before we can know about the vascular dynamics. Now, As you got Doppler color Doppler is concerned, that will come up as you got the discussion latter part of it is concerned. But most of the time, if the Doppler comes that yes, he has got a vasculogenic cause, then obviously we have to think of putting a penile prosthesis, either a vacuum reduction device or a intracavernosal injection. If that also is not working, we can suggest with a lot of reservation, we can think that this young man, I think we need to put a penile prosthesis after excluding very thoroughly the psychogenic cause. So this is what, in summary, I would like to say in these two cases. Thank you.
Thank you, sir, for all the wonderful explanations for the first two cases. And for the next two cases, I would like to invite Dr. Shivam. He will be presenting the next two cases, third and fourth. He'll be giving the key and he'll also be deliberating on the possible explanations to them. And I also thank him for helping me to coordinate while my bandwidth was down because of the strong winds around my area. Thank you so much, sir. Over to you.
Thank you, Raman. You're always welcome. And I would request Navneet to kindly allow me to share my presentation. Navneet, please allow me. Right, thank you. So I would congratulate both Urological Society of India and Indian School of Urology for having started this great initiative. So this case is the case number 3, which was a 22-year-old gentleman who presented with complaints of painful, persistent erection for last 8 hours. The first question was, what is this condition called and how is it defined? So I think it's a very simple question. The condition is called priapism, and it is defined as full or partial erection that continues for more than 4 hours beyond sexual stimulation and orgasm, or is unrelated to sexual stimulation. So the priapism word comes from Priapus, who is considered as a Greek god and as a god of fertility. So the second question was, what are the different types of priapism? So again, very simple question, that 3 main types: low flow ischemic priapism, which is the commonest type, and this is the commonest type which you get after an intracorporeal injection of vasoactive drug also. And the other one is a non-ischemic type, which is less common, and here the penis is not that rigid and usually it is painless, and usually it occurs post-traumatic due to some arteriovenous fistula or aneurysm formation. And the third is the stuttering or recurrent prolonged erections. So many of these patients, you will find that they have recurrent prolonged erections. It may occur daily even. So this is very common in patients who have sickle cell anemia and other coagulopathies. So the other question was, apart from pain and duration of erection, what relevant history would you like to ask in such a patient who comes with a prolonged erection and priapism? So we need to take a proper history of the previous episodes of priapism and how he was treated. Has he been taking any erectogenic drug? The commonest cause for this prolonged erection or priapism would be a patient who has been put on a diagnostic penile Doppler with a papaverine injection or a Bimex or a Trimex, and he has not been asked to wait in the office, and he develops a prolonged erection priapism. So this is the commonest. Sometimes, very anecdotally, we can have with sildenafil, 1 or 2 case reports have been reported. And then we need to also ask about other medications like drugs like trazodone and etc. may cause sometimes prolonged erection. Recreational drugs like cocaine and other things can also cause priapism. Then very important is the history of any sickle cell disease or hemoglobinopathies or hypercoagulable states, which can result in such erections. And then if there is a history of trauma to the pelvis or perineum region or the penis itself, that can result in a kind of arteriovenous fistula and priapism, which results in a non-ischemic variety of priapism, and which is usually painless and not that rigid. The next question was enumerate the management in an emergency. So if such a case comes with 8 hours erection, then first of all, you need to distinguish between a non-ischemic and ischemic priapism. That can be done with a history of it is painful, it goes in favor of ischemic. And then you take the proper history of the patient, various drugs he has taken. And then you investigate him further, if necessary, by a Doppler ultrasound. Doppler ultrasound in an ischemic priapism will show a constricted artery, whereas in non-ischemic, the artery would be normal, diameter would be normal. Further investigation could be done with a corporal blood gas analysis sometimes. So usually in an ischemic variety, you will have an acidic pH going less than 7.25. The PO2 will go less than 30, PCO2 will go above 60. So these are the things which can differentiate between ischemic and non-ischemic. So these patients usually have a very painful erection in ischemic variety. So analgesic needs to be given, and immediately you aspirate the clotted blood and then inject phenylephrine. Phenylephrine is as you know, is a alpha stimulant, and it is even usually given in the dose of 250 microgram, or even diluted adrenaline in the dose of 25 to 50 microgram can be given every 10 to 15 minutes, and you need to monitor the heart rate and blood pressure. And if it doesn't work, then you need to aspirate and irrigate. And sometimes if that doesn't work, then you have to have a slow extended corporal drainage, which can continue for maybe 1 hour or 2 hours till the all clotted blood comes out and you find that the bright red blood coming out. And then you again inject the phenylephrine. So this is the way you usually treat in the emergency. And if these patients come later, maybe after 24 hours, then you may have to resort to the various surgical options. And surgical options are basically shunts. And the shunts could be these percutaneous distal shunts, proximal shunts, and saphenous vein shunt and the deep dorsal vein shunt. So nowadays, the rest of the shunts are usually not done. Usually we do a T shunt with a snake maneuvering with a corporal dilatation of the whole corporal body till the proximal aspect with a Higgard's dilator. So that will improve the erection if it has to. Otherwise, we need to implant this patient later on, maybe, because these patients will develop fibrosis of the penis and will result in erectile dysfunction. Sometimes in acute setting also, you can put a penile implant. So this is just an algorithm how you do. So that we have already discussed. So the next case was a 40-year-old male who complains of pain while having erection for the past 6 months. And the penis progressively deviates towards the left when erect, and he is worried that he has a tumor and he is able to palpate a hard mass on his penis. So what is the likely diagnosis? Again, a very simple question, Peyronie's disease. So this was described first by Fallopius and then popularized by Francois Guigo de la Peyronie in 1743, also known as inderatio penis plastica. It's a fibrosing condition of the tunica albuginea caused by repetitive microtrauma, and which results in a fibrous plaque subtunically, which causes Peyronie's disease. The next question was, what are the associated conditions? This has been seen that many of these patients will have associated Dupuytren's contracture on palm, or it could be a Lederhos's disease, which is found usually in the plantar fascia on the foot. And another condition that can be associated is tympanosclerosis. So what are the important points you need to note in such a patient of Peyronie's disease? Because we know Peyronie's disease usually has 2 phases. One is the acute phase, where the erections are usually painful, and the plaque also increases in size, and the deformity also increases. And the other phase is the chronic phase, where the pain disappears and the lesion also gets stabilized. So you need to differentiate between these 2 stages, and you also need to know that whether the patient is able to penetrate with the deformity. If he's able to penetrate and have a normal sex, then probably he would not require surgery. So most of these cases are self-limiting and they're divided into these two phases. And usually the acute phase will last from 12 to 18 months. So the next question was two important investigations to consider this. So we know the history is very important in this patient and the physical examination. On physical examination, you will find a fibrotic plaque either on the dorsal or the ventral region or maybe on the lateral region, or maybe there may be multiple plaques also. So usually 2/3 of the cases you find a dorsal penile plaque. So that's usual. You can diagnose on history and physical examination. But if you want to further investigate, you can do a penile ultrasound where you can able to see the fibrotic plaque, and if it is calcified or sometimes it undergoes bony changes also. So that can be seen on ultrasound. And before embarking for surgery, we need to know whether the patients have erectile dysfunction, and that can be done by a penile Doppler study. And the degree of curvature, again, is very important, whether he needs a surgery or not, and what type of surgery. That can be done by a goniometer, or it can be, we can ask the patient to take a photograph of the penis on two views, lateral and from front, so that we know exactly what is the degree of curvature that he is suffering from. Next question was, what is the non-surgical management in these patients? So it's very important. The patient is usually very anxious about a lesion in the penis. He feels that this could be cancerous. So the first and the foremost important thing in this patient is to reassure them that don't worry, this is not a cancerous disease. This is a self-limiting disease. You can continue to have intercourse and this can be treated later on. So don't worry at all. The medical management is basically treating the pain by non-steroidal anti-inflammatory drugs. There are other oral therapies, but they have unequivocal results on the level of evidence, on the evidence that we have. That could be tamoxifen, Potaba, pentoxifylline, colchicine, and even levocarnitine and vitamin E. The other treatment is the intralesional injections. The only FDA approved is a collagenase, also known by the name of Xiaflex. And people have also a lot of studies with verapamil, hyaluronidase, and they have even given steroid. Other two things which are usually more of experimental and not established role is the extracorporeal shockwave therapy. And another is a penile traction device or a vacuum erection device. And when is surgery indicated? Again, very important thing, if the curvature is more than 30 to 45 degrees, so that it doesn't allow the person to penetrate, to have a regular sex or intercourse, and that is the usual indication for surgery. And what are the various types of surgery? Again, it would depend upon the severity of the curvature, the complexity of the curvature, the penile length. And so the simplest surgery is doing application. If the penile length is normal, patient having normal erectile function, and the curvature is not more than 60 degrees. The second important is the incision or excision followed by grafting. So if the patient has normal erection, but the penile length is a concern, and if he has a complex curvature like a hinge or a circumferential plaque, or the curvature or the degree is more than 60 degrees. And the third is the penile implant. Like if the patient is having poor erection and which is not responding to PD5 inhibitors, then we need to put a penile implant in this patient, along with sometimes we add remodeling or plication or grafting in these patients. So these are the various materials that can be used for grafting. It includes dermis, the saphenous vein, the tunica vaginalis, albuginia, fascia lata, and sometimes even cadaveric or bovine pericardium or SIS or Dacron Gore-Tex is usually not used nowadays. So this is the algorithm of surgical treatment. If he has ED, which is not responding, do penile implant. If the curvature is less than 45 degrees, penile length is normal, put a plication. If the curvature is more than 60, short penis, do a penile lengthening procedure or an incision-excision grafting. So thank you. I think I will stop at here.
Thank you, Shivam sir, for the wonderful deliberations. And I think that you have crisply defined the key and also given apt explanations. And now for the next few cases, from case 5, 6, and 7, I would like to invite Dr. Vinod to provide the key to the students and also to teach something around the questions to the students. So over to Vinod sir, please.
Is my slides visible?
Absolutely, sir. We can see them.
Good evening, everybody. I thank USI for giving our andrology subspecialty the honor of having the first OSCE. As we all know, the andrology is the most important specialty where the surgeon enjoys and the patient also enjoys. No other specialty have that rare distinction. So my young friends, you be comfortable and enjoy a few basic points from andrology. So our sixth question was a very basic question. A married couple is visiting the clinic. They were trying to have a kid, but was unsuccessful. So the question was, what are the essential points in the history to diagnose infertility as per WHO definition? So what does WHO, how does it define the infertility? Infertility is a disease of the male or female reproductive system defined by the failure to achieve a pregnancy after 12 months or more. So that is a key point there. After 12 months or more, regular, it should be a regular intercourse where all the reproductive, the ovulatory period is covered. It should be a regular intercourse and it should be unprotected. So these are the 3 points we want from this question: 12 months, regular, unprotected intercourse. So why this 12 months? You will be wondering, because we are including this 12 months because within 12 months, there is the cumulative pregnancy rate is 92% if they are utilizing the 12 cycles. If you take the total pregnancy, those who are utilizing 12 cycles will be 98%. So to conclude, within 12 months, we give them a reasonable chance to have a normal pregnancy. That is why the 12 months is kept in the WHO definition. But WHO definition is not the only thing. When you come to andrology, we need to have a more modification of the definition. We have seen that previously the terminology disease was not used for infertility, but now it is a disease where you can claim for insurance. In some of the countries, they have started giving insurance because it is a disease. And now it is being described as a disability also, because you are not able to have a kid as a novel person. So that the disability claims will also come to you. That is a broader aspect of improving that definition. So it is a disease and it is considered as a disability also. This is done by the ICMAT, International Committee for Monitoring the Assistive Reproductive Technology. And also you should know that infertility is not a simple thing nowadays, because our definitions are changing. The couple is different. After that LGBTQ group and everybody is coming, suppose one person is coming to you and telling that I want to have a kid, but I don't want to marry, I don't have a partner, I am ready to give the sperm. And a surrogate mother has to be taken and things like that. So there are situations like that. So that definition is modified by ICMAT. You can see that it is by unprotected sexual intercourse. This up to this is WHO definition. After that, or due to an impairment of a person's capacity to reproduce, either as an individual or with his or her partner. So everything is included in the definition nowadays. And it is a disease and it is a disability also. Now the second part of the question was, what is secondary infertility? That as per the routine definition, it is inability to conceive after a previous pregnancy. Pregnancy means it includes abortions also. It is not live birth. Pregnancy is actually including abortion and live births. But when you look at the ICMAR terminologies, there is two other things. One is a secondary male infertility and another one is a secondary female infertility. Why this is important? You have a couple, they're coming to you and telling that we are not having kids, but this man has already had a kid in another marriage, or or without a marriage, or he had a history of pregnancy with a partner. So that person may not have a problem. So that is, so we may be looking at them in a different, investigating them in a different light. So that is secondary male infertility. Same thing applies to the female also. So that is secondary female infertility. She had a kid or a pregnancy with another partner. That also will be included. So that is secondary female infertility, a more precise term. Now the third one is, what are the important instructions to be given to the patient before a sample collection. This is a classic thing which is given in all the textbooks, abstinence of 2 days, or some textbooks may say 3 or 4, but anyway, it has to be a fixed one when you are practicing. And complete semen to be collected, not part of the semen. If it is spilled off, it should not be collected. It should be in a wide mouth bottle, and collection should be done in the lab or hospital, or otherwise it has to reach the lab within 30 to 45 minutes of collection. So these are all standard things, and these are the things we want from that OSCE question. The next question was, name the instrument, what this is used for. This is Pradas orchidometer. And what are the alternatives for this instrument? This is used for assessing the size of the testis. The other options are, one is caliper, which is called as a Seeger's caliper. This is a picture in the Campbell itself. Another option you can do is an ultrasound. If you're doing an ultrasound with a good sonologist, they can clearly measure the size of the testis. And you can even write palpation. We may give a credit for that, but that is not the appropriate. These three are the standard techniques to assess the size of the testis. And this Micham's maxim is for the palpation of vas, because all other things you can diagnose by ultrasound or investigations, but vas, identifying the vas, is just a clinical acumen, your clinical skill. So how to palpate a vas? If you are looking at our old textbooks, it is told that it is felt like a cord-like thing. And if you are not sure that it is, vas, then it is not vas. That is a maxim used to teach us. But even in clinics, you may miss a vas. You don't worry about that, because you have azoospermia, you have other things, you have indirect methods of telling that he is not having a vas. But the problem comes when you are doing a vasectomy. When you are doing a vasectomy and if you are missing a vas, then you are in real trouble. Then you will have to keep crores of rupees as compensation. So in that situation, that is why MECAMs have brought out this maxim. If the vas is slipping out of the hand during a vasectomy more than 3 times, it is not vas. That was his saying when he's doing a vasectomy. So it was coined while doing a vasectomy, not during a clinical examination. The next case, the third case, that is a case 7, is a patient presented to the emergency department with a penile swelling. The swelling was sudden onset following a pop sound. This pop sound is very, very classical. There is no other diagnosis than a fracture of penis in this one. But those who have managed a fractured penis might very well know that this pop sound may be from the bed itself. It may not be from his penis, but he may tell that he has heard a pop sound. The only trouble is when you are making a diagnosis, you will be exploring the penis. And if you are finding a negative, if you are having a negative surgery, then you can have some problems. So how it happens, the tunica of the erect penis actually thins out approximately 0.25 mm on expansion. And the engorged corpora, if it is having a sudden buckling, a strain of buckling, up to 1500 millimeters of mercury pressure can be created. But I don't know how it happens, but most of the fracture penis comes in a normal intercourse. But we have never seen a fracture penis coming in a rape attempt. So it's always a violent love which is creating this fracture penis. What are the differential diagnosis? I am not going to the other possibilities. The diagnosis which we may be misled is a rupture of the dorsal artery of penis, rupture of the dorsal vein, or a rupture of the suspensory ligament of the penis. These are some events which can happen in a violent intercourse or in a forceful intercourse. And eggplant deformity and rolling sign are described before this condition. What are they? Both are clinical signs. One is a sign of inspection and one is a sign of palpation. Eggplant deformity is localized penile swelling, discoloration and deviation to one side, opposite the fracture site. So where there is a fracture site, there will be more hematoma and there will be enlargement, and the other side will be little bit shorter. So there will be a deviation to one side. I'll be showing a picture. And rolling sign is a clinical sign. This is where how we locate the hematoma. If we are having the rolling sign, you find a hematoma, you can confidently explore. Otherwise, it is better to have an imaging before you explore. Otherwise, you will be finding trouble peroperatively. This is a classic eggplant. You can see the penis is also almost similar to that. What does it indicate if you have noticed blood at the urethral meatus at the time of presentation? It indicates extension to the corpus spongiosum and a urethral injury. So what additional investigation will you do in that setting? You can either finish off with a ureterogram and MRI penis or do an MRI penis. And there are some schools which tell that even in ordinary fracture penis, you have to do a ureterogram. But some of the literature is not in favor of that. So how it happens? If you are looking at the MRI of fracture penis, you can see this is a corpus spongiosum, corpus cavernosum. You can see the defect here, and this is the this is another picture where you have this is a hematoma, and you have the corpus cavernosum on either side and the corpus spongiosum here. You can see the defect in the corpus cavernosum and here in the corpus spongiosum. So that finishes our questions, the 3 questions, 5, 6, and 7. Over to you, Raman.
Thank you, Vinod sir. Again, wonderful pictures. It was very good to see so many pictures again in andrology and to learn from you. And now I think we should move to the last 3 questions, which my dear friend Pramod is going to elaborate on. So Pramod, let's move ahead with the 8th, 9th, and 10th question, which are all around your area of interest. Over to you, Pramod. Pramod, we can see your slides.
Yeah, thanks, Dr. Raman. Yeah, so the 8th question was about the elderly guy asking for a penile implant. So how are the penile implants broadly classified? So there are 2 broad classifications. One is the semi-rigid, which is also called as the malleable, and the second is the inflatable one. Yeah, so in the malleable, there are 2 components. One, some implants may have a memory and some do not have. For example, if you see the video here, if you see this, this is a Shah implant. So this does not have a memory. That means the moment you leave this, it comes back to its primary position. Whereas you see this as an example, you see this Spectra implant. So this, when you fold it, this has some amount of a memory. So this indicates this is an implant which has a memory, and this is something which does not have a memory. Okay. And then coming to the inflatable implants, so that there's a two-piece implant wherein you can see here. So
Pramod, are you sharing your screen or?
So no, I think it's
and the answers.
No
pictures.
Okay, maybe you can see now my video.
Okay.
Yes, Pramod, I think this is better in terms of explaining the implant. Then you can go back to your screen sharing.
Okay. Yeah. Okay. Yeah. So so this is a two-piece implant wherein this is a cylinder. These two are the cylinders, and this is the pump which is kept in the scrotum. These two cylinders are kept in the corpora cavernosa. And this is a three-piece inflatable implant. Just show you. Okay, yeah. So this is a reservoir, and this is the pump which is in the scrotum. The reservoir, again, it can be kept around the bladder or in the ectopic location. And these two are the cylinders which are kept in the corpora cavernosa. So this is about the penile implant, the different types of penile implants. I will again start sharing my slides. Okay, the second question was, what are the perioperative strategies that you follow to avoid a penile prosthesis infection? So here you need to do a urine culture. It is a recommended investigation. And if it is positive, of course, that needs to be treated. And for any surgery, smoking has a level 1 evidence that smoking should be quit 4 weeks prior to the surgery. And the recommendation is not just the betadine solution for painting doing this prior to the surgery. Instead, alcohol-based chlorhexidine scrub to be done, and on-table hair removal by clippers and not by razors. And the most important is the no-touch technique. That is to avoid the prosthesis getting in touch with the skin, because most of the penile prosthesis infections, the cultures have reported streptococcus. So the skin is the cause. So hence no-touch technique is most important. And again, there are antibiotic-coated implants wherein some of the implants are coated with rifampicin. And also prophylactic antibiotics to be given. One is prior to the surgery, and also intraoperatively, we use this antibiotic solutions for the corporal wash. Yeah, and the next question was, what are the different approaches to place an implant? The most common the approach is the penoscrotal, because most of us are oriented with the urethral reconstruction. So penoscrotal is the most commonly done approach. The next is the infrapubic, and subcoronal is used only for the malleable implant in some cases. Perineal approach is used when you are doing a simultaneous continence surgery. Like, for example, if you're doing a penile implant and placing a male urethral sling or an artificial sphincter, then you can put a big perineal incision which can cover up both penile implant and the sphincter or the urethral sling surgeries. And so what are the common complications that you need to explain to the patient in the OPD is, these are all the complications. Infection, yes. And I told you what are the precautions that needs to be taken. Bleeding, yes, any surgery. Hematoma. Floppy glands is when you place an undersized implant. That is, if you place a smaller size implant, you are not judged the size, what is the right size for this patient, and he may have a floppy glands, and which may require a glandoplexy at a later date. And urethral injuries can happen, especially in cases of Peyronie's disease, where there is corporal fibrosis because of any previous infection or any previous surgery. So during the corporal dilatation, you might injure the urethra. And again, in the same cases as Peyronie's disease or difficult corporal fibrosis, you can also expect a distal perforation that is near the glands or in the proximal corporal perforations. And yes, inflatable implants can undergo a mechanical failure which needs a replacement. Glands necrosis is seen when a patient who has undergone a urethroplasty before because when somebody has undergone erythroplasty, that means the ventral blood supply is already, to some extent, it is compromised. And then now you have placed an implant which is too tight, which may compromise the dorsal supply as well. So in that case, rarely the glans necrosis can happen, and it is one of the most dreaded complications, and it is not very common. It's quite rare. Reservoir herniation, yes, in thin individuals, or if the reservoir is not placed at a proper place, it can herniate. Yeah, so moving on to the next question. Here is an, we all know the question. Basically, here we need to decide whether this guy needs VAS reconstruction, or do we have to do a surgical sperm retrieval and IVF. So we need to decide. So to decide between these two things, we need to we need to get these history details. That is one, whether is there any previous history of inguinal surgery. The reason this is needed is because if there is a block, anyway, there is a block at the vasectomy side. If there is an additional block at the inguinal hernia side, then the reconstruction gets really difficult. And also in the presence of the mesh, dissecting VAS will be near to impossible. And second is whether the new partner has any bad obstetric history. Of course, that goes in favor of ART, that is assisted reproductive technique, which is IVF. And the third thing is you need to know the location of the vasectomy. If you palpate the scrotum and palpate the spermatic cord, you will be able to localize the sperm granuloma, which will usually be formed at the site of the vasectomy, so that it will give you some idea of where to put the incision and how to mobilize the vas, both the distal and the proximal ends. And also, it's also important to palpate the epididymis, so that if it is turgid, that means yes, very unlikely to be a testicular failure as the cause. And if it is collapsed, yes, you might expect no sperms when you explore the vas. And also important is the testicular size. Very small testes, like less than 2 centimeters, then you might prefer to go for again, it's not a hardcore rule. Especially when we have very small testes, we usually prefer to go for an ART. Okay, so in this case, so what are the points that favor a vasectomy reversal than when compared to an IVF? So vasectomy reversal, yes, if done well, high success rates. And yes, if the couple want to have a second child, maybe after 2-3 years, yes, if the vasectomy reversal works, yes, multiple pregnancies can happen. And yes, when you compare it to the IVF, vasectomy reversal is cost effective and also safe when you compare it to the total adverse effects of the IVF and also the surgical sperm retrieval.
Change the slide also.
Yeah, I'm changing. Is it moving?
Yes, now it's moving. Yes.
Okay. So the next question was, what are the things in favor of going in for an IVF, or that is assisted reproductive technique? When all cases of vasectomy reversal needs to undergo an anti-sperm antibody test. If you see more antibodies attached to the head of the sperms, then the vasectomy reversal may not help. So in that case, one has to go for an ART. And of course, with IVF, the outcomes are early. Maybe in the next 1 or 2 months, you will get to know what are the embryos and all that information. And also, if the female factors, such as the wife has a very low AMH, or if she has poor ovarian reserve, or the fallopian tube blocks, and of course, these go in favor of going in for an IVF instead of a vasectomy reversal. So what procedures, what consent you would like to take when you plan this reconstruction? That is, you need to take, of course, you're planning for a vasovasostomy, which has a success rate of 60 to 90%. But when you explore the vas, when you mobilize the testicular end of the vas, if you see a paste-like material or the fluid that comes out from the testicular end, you do an analysis, you observe the fluid under the microscope. If you don't see any sperms, then you might have to do a vasoepididymostomy instead of a vasovasostomy. And again, the success rates vary. It may vary from 20 to 30%. Again, in high volume centers where they do more than 10 vas reconstructions in a year, the success rates may be more than 30%, but average it is taken as 20 to 30%. So coming to the last case, here is a 35-year-old couple who have completed the family, which is most important. And this guy has a Klinefelter syndrome, and he has come now with very low testosterone levels, asking for a testosterone replacement therapy. Again, if the patient had not completed family, they had no children yet, of course, testosterone replacement therapy is not indicated. They have completed family, yes. So yes, we can go ahead with the testosterone here. So different formulations, oral tablets just got FDA approval in 2019, just 2 years back. Injectables have been there since a very long time. There are gels, you can apply it on a daily basis over the shoulders or over the anterior abdomen. And there are transdermal patches. Patches are currently not available in India as far as I know. Subcutaneous pellets, these are inserted in the subcutaneous region, in the gluteal region. Yes, some of the compounding pharmacies in India are making these pellets. So which is the least recommended formulation among the above? Oral tablets are the one which are least recommended, because high doses of these oral tablets needs to be taken because of the the metabolism, and potentially there are significant liver effects and the first pass metabolism leading to ineffective therapy. And all other formulations, they bypass the liver, whereas this oral medication has to go through the liver. And suppose if he wants to prefer an injectable, what are the options and how do you counsel? So in the United States and in most of the Western countries, the testosterone cypionate is the most commonly used drug, and it is a self-administration, just like how people take insulins in diabetes. Similarly, the option 2 here that I am saying is the cypionate, 100 mg IM once a week or 200 mg every alternate week. Either of them is fine. And then you either increase or decrease the dosage after you do a follow-up testosterone at 4 weeks. And this cypionate, like insulin, needs to be refrigerated. In India, what is commonly done is the option 1, which is basically a testosterone undeconate 1 gram injections given once in 3 months. And in the United States, this has a black box warning saying that it can cause pulmonary oil embolism. And hence the patient needs to be observed for 30 minutes after the injection. And it is not a self-injection. That is, undeconate is not a self-injection, whereas cypionates can be taken by the patient himself at home. So one disadvantage and advantage of the gels, yes, advantage is that a consistent serum levels are achieved because you apply the gel on a daily basis, and of course it is painless. The disadvantage is that here this guy has a 2-year-old kid at home, so there is always a theoretical transfer of this gel getting transferred to the child or even the wife also. So the last question was, how do you follow these patients who are on testosterone replacement therapy? Specific test that you do is hemoglobin and PCV, because there is always a theoretical risk of these patients who are on TRT developing polycythemia. So hence you need to monitor that. And PSA may not be very relevant in this 35-year-old guy, but as a standard, anybody who is on TRT, at least it is better to get a baseline PSA so that it will be helpful for you to check his levels after a few years. And of course, total testosterone to know the response of the therapy. The follow-up usually is at 1 month, 3 months, and 6 months, and then every yearly. So that's the end of the 10th case.
Thank you very much,
Raman.
Dr. Pramod, for again the crisp explanations. I think, sir, we are already shooting the time.
Raman, just give me a few minutes. I'll just post the questions for the other agents which have come in the chat box. Can I take this?
We have been trying to reply to the chat box questions on a regular basis, so we've answered most of them.
Yeah, but it will be for all the agents. We'll take questions live. Okay, I'll put this first question to Dr. Hota. What dose of PDE5 inhibitor should be given in psychogenic ED after positive tadalafil test for initial few encounter? This question is from Akif Zia.
Yeah, I think the preferred, I have already answered it. The preferred, because of the lot of anxiety, the preferred PDE5 inhibitor is the sildenafil. And younger, we use about 100 milligram in the office test. And we do a repeat test also. If in the first test we don't have a positive response. Now, we can give the same drug, which has already given him an erection in the office test. We should not switch over to another PDE5 inhibitor. Once we are doing a sildenafil, we should give him the same dose for the initial fear encounter to boost his confidence. That should be the policy. In younger male, the preferred drug now, newer drugs are coming, avanapil, but as of our experience, I think sildenafil is the drug of choice for office test. And to boost the confidence, you have to give the same dose at which he had got an erection.
Okay. Now, I'll just put this question for the viewers. Do you think that recreational use of these PDF inhibitors can lead to some sort of addiction? And if you take it off, lead to decreased performance?
I think, let me give an example. It is a fact. There is a dependency. We don't say that there is a decrease in the performance, but there is a dependency. A man coming with a ED, and we have evaluated him and we have given a PDE5 inhibitors. Now, the erection that he gets, he always compare with his usual erection. And this is not only erection, good erection, and also a sustained erection. So that's the reason he feels that possibly with the drug, he has a better erection. So there is a dependency. Now, that is the most difficult part when we are continuing the person with PDE5 inhibitors. The same case with also the ICBAT. The same situation is also with ICBAT. So there is also another aspect is tachyphylaxis. So when you start with a lower dose, initially he may respond. After about sometimes a month or years, he'll say that I'm not having that type of erection that I used to have with the initial dose. In that case, we have to also increase the dose, and it is called as tachyphylaxis. So these are the two situations. One is dependency, and second is tachyphylaxis, which should bear in mind.
Okay. Thank you, Dr. Hota. I'll move on to the next question. Also, this has been answered by Vinod. The question is from Priyanka. Can cavanosogram be done to look for fistula instead of MRI pelvis? Dr. Vinod, are you there?
Yeah, I'm here.
Yeah.
I have answered in that. If you're doing a cavanosogram, you may not get that urethral injury because it can be a separate thing also. If it is communicating, you may get a urethral injury in that. Otherwise, you may miss it. So when you have the MRI, I think that will be the best thing if you can do that, because for identifying the defect in the tunica albuginea in corpora cavernosa and spongosa will be okay with the MRI if possible. Otherwise, you can just by clinical sense, you can explore, find it out. And even in small urethral injuries will heal by 1 week of catheterization. So that may not create a problem also.
Thank you, Vinod. Shivam, can you take this question? This question is from Nikhil. How do you judge the correct size of implant? I think we did cover it in the class, which was taken by Raman, the penile implants. But Shivam, if you can take this question for our residents.
I think Raman has already said this. We have a measuring device by which we can measure the implant and the exact size of the implant that has to be implanted. So first you put either this can be measured with the measuring device, and this can be put distally in the corpora through the incision, and then you just measure exactly the point at which you see that the proximal dilator has gone distal, and then you measure on the distal side. So when you add these two, that will be the total length of the implant that is required. And then we have rear tip extenders also. So you have to just subtract 1 or 2 centimeters for using these rear tip extenders from the total length of the implant that is to be used.
Thank you, Dr.
Can I
Shivam.
add a point to that, sir?
Yes.
With the Shah implant, deciding the size is slightly different from all other international other implants. In the Shah implant, you decide the size basically on the stretched penile length. If the stretched penile length is somewhere 12 or 13, then you choose a 11 size implant. Sorry, if there is a 10 or 11, you choose 11 size. It's basically dependent on the stretched penile length when it comes to Shah implant, whereas all other implants like Tectra, Genesis, and the inflatable implants, you decide the size based on the cavernosal length, that is corporal length. You use a device called furlough and you measure both the proximal and the distal corporotomy of this corporal length. And then you add up and then you decide the length of the implant.
Right, because there are 3 or 4 types of SHA plant. So which one you need to have in the OT? That is, for that we need to have a penile stretch length. But again, it is important to measure during the surgery also, both distal and proximal corpora, and then find out exactly which implant has to be put.
I think both of you have very nicely this thing. Just I will add one thing. You know, the initial assessment is the stretch penile length, but exact assessment during the surgery. You know, you should have if you have 11 WH11, then I think you have 11 as well as 13. Yeah. So you may modify at the time of surgery also. So you have to go for a measurement to make a rough assessment, the stretch penile length. At the time of surgery, again you reassess, and accordingly you tailor the size. Thank you.
One more thing that can be added and told to the residents, that the beauty of Shah's penile prosthesis is not only the length, but even the diameter of the penile implant can be changed. So there are 2 sleeves on the implant. If you remove these sleeves, you can have a smaller diameter. So a patient having a kind of a narrow penis can we can put a narrow diameter penile implant Shah's. So that's a very good advantage of Shah's prosthesis.
Yeah, Shivam very nicely described, and comments from Dr. Hota and Pramod Veldikkan. I'll come to the last question from the chat box. This is from Sitaram. Role need of PSA testing, vasectomy, reversal surgery. I think Raman has answered. Raman, will you take it for other agents?
So, sir, basically, PSA testing, you know, I think it doesn't, as per literature, and also before answering, I did check on something if latest had come around it. So as to not, you know, misguide any of the residents. So there is no role as such to do this testing of PSA before any reversal surgery. So I think it doesn't require a lot of explanation around it. The both of them do not seem to be too much connected.
Only thing is probably they have said, because there was a few studies initially that this vasectomy can cause carcinoma prostate. But this has been disproved. So
there is no role.
Yes. Yes.
Yeah, so for Sitaram, there's no need of PSA testing. Any PSA testing increase after vasectomy reversal is not due to CA prostate. It may be operational. That is well documented in the literature. So that's all from our panelist and Dr. Raman. And now we move on to the this closing of this program, and very nicely scripted program, nice 10 question encompassing all the fields of andrology and men health, very practical scenarios. I think when I was just seeing the OSCEs coming up live and being put to the right, and I was thinking that we may have, once this program becomes successful with other specialties, we may have OSCE also, objective structured practical exam, something like that, where in one center we can do a similar sort of resident activity from one center and being related to others. Anyway, that is later to be discussed within ourselves, but a very nice program. I think the residents have still logged in till the answers or all their doubts were cleared, the keys were answered, and I think now I hand over to Dr. Rajiv Sood and Dr. Keshav for the...
Can I have a word, if you permit?
Yeah. Yes, sir.
Yeah. You know, wonderful program has been crafted by the USI Andrology subspecialty. A lot of efforts has been made by Raman and the team. Now, this OSCE program was designed by, this is the first, you know, this is the first program by the USI. This is basically to enhance the analytical skill of the students and communication. Very nicely crafted. I think it has served the purpose. This is what I wanted to convey on behalf of the Andrology subsection, and thanks to the USI for giving this opportunity.
First, Dr. Keshav and then Dr. Rajiv Sood for the closing comment.
Thank you, Dr. Arun. I think it was a wonderful program by the Andrology subsection. It was great session with a lot of practical information. I think the residents, apart from answering the questions, learned a lot by the key answers and the explanations. And the faculty, you see, had put in a lot of efforts to create their own slides for answering those with a lot of inputs to these questions. And this is what the residents would learn from. And it was a wonderful discussion on the topics which carried from priapism, penile implants, everything. It was a practical session. We need to debate on how to improve this. We know that this session was wonderful, but we need to have some inputs to see whether we can make it much more interactive, or a sort of exam sort of thing itself, having stations which the OSCE stations are there in the physical exams. So thank you, the andrology subsection, Dr. Hota, Dr. Raman, Vinod, Shivam, Pramod, all of you have put in a lot of efforts for this program. On behalf of the USI, I congratulate your subsection for doing this. And now I would invite the chairman of the ISU for his closing remarks. Over to you, Dr. Rajiv Sood.
Thank you, Dr. Keshav. It was wonderful program, and as it was conceptualized, I think we were very near to that implementation. Now the faculty was class, and it was really which all started in USI. You know, the specialties, subspecialties started, and I was associated as the deputy convener for 2 years and then convener for 2 years. I was with the Rupincha, deputy convener and then convener for andrology. But latest addition is men's health. And as I told in the beginning, that subspecialty based functioning is becoming very, very important. 10 questions in OSCE, which were addressed today, if we complete all the subspecialties, these OSCE programs, then it will become the perfect replica of what was done by National Board of Examination. This is increasing the understanding of the subject, of the subspecialty, and will create a lot of interest. Today's program was special, as this has given the template for the residents to think about all what is going to happen if these virtual classrooms and virtual examination assessment, e-assessments continue. Then I think because of this pandemic also, this kind of exams are going to continue, and not only going to continue, this will become the norm even after the pandemic is over. So we are on the right path. USI is on the right path. Raman has done great work in framing all, and along with that, Dr. Pramod, Dr. Hota, Shivam, and all, Vinod, all has done wonderful job. This was the dream of Keshav also. And especially I'll congratulate Arun Chawla, who was desperate that OSCE should be done, and it has become the reality. And Dr. Keshav wanted it to start as soon as possible. And I think 4 or 5 days back only, we thought that can we do it in 4 or 5 days? And the entire andrology subspecialty, all the members have come forward positively, and they have done wonderful job. And we have replicated whatever was done by national board, and whatever suggestions come, feedback come, that will be incorporated for other subspecialties. There will be rewards for the residents who are now answering. This is the exercise which we will be discussing internally, and deciding how to give awards and rewards with these subspecialty based activities. And this is a great chapter which has started in our Indian School of Urology. Congratulations to all. Thanks to the office support by Navneet, Kiran, and all, and also entire team and residents and their teaching faculty at their institutions who will be contributing, I'm sure, more and more in the other OSCE exams, which are going to be, the calendar will come, and Keshav is preparing that along with the Indian School of Urology, and it will be publicized soon, so that the residents are better prepared. They come, they go through the subject, they read, they learn it, and they discuss it here. Thank you very much for today's evening, and great month which is coming, that is Men's Health Month, month of June. We have been appreciated by Indian Medical Association now, and they have constituted for the first time National Standing Committee on Men's Health. And I think along with me, 2-3 members are here. Dr. Hota is also there as the member of the National Standing Committee. Dr. Rajendra Singh Sinam is also there. And 2 or 3 more members are, I have to suggest and add. And we are going to observe on 20th of June, a big day along with the subspecialty section of USI, with the National Committee of National Standing Committee of Indian Medical Association on Andrology and Men's Health. This is the achievement that as urologist, as andrologist, as men's health specialist, we are penetrating there and in the national scene. Thank you very much. Thanks for the evening, and good night. Thank you.
Thank you,
Thank you
sir.
so much,
Thank
sir.
you
All
very
of
much.
you
Thank you so
to send the feedbacks. I want the feedback from the residents about the program on, and if you have any feedbacks on how to improve upon this, please write to us at usi-secretary@gmail.com. Thank you. Thank you, all of you. Thanks, Mr. Navneet and Kiran.
Thank you so much,
Thank
sir.
you.
Thank you. Thanks
Thank
to
you.
all of you, sir.
Bye.
Thank
Good
you.
night, sir. Stay
Good night.
safe,
Good
stay
night.
well, sir.
Good
Stay
night.
healthy.
And special thanks to Dr. Arun Chavla and Raman Tawar.
Yes. Thank you, sir. Thank you.
Good night.
Bye, sir. Good night, sir.
Good night.